Tu podcast w głowie się mieści.
Well, we made it.
Yeah, we made it finally. Every problem can be solved. Yeah.
Maybe.
Yeah.
But this was.
So with me here today, I have an honor to have an interview with Professor Edny Foa. And I know that if I want to say everything that you've done, a lot of great things that you've done, so I probably need to do a couple of episodes to like say it.
Well, let's keep it.
Okay, but you were awarded by New York Times, as one of the 100 most influential people, in the world. You were also awarded by the Academy of Cognitive Behavioral Therapy Award for the Lifetime Achievement. You were also awarded by American Psychological Association in 2010, also in the field of trauma psychology. So like you have many awards.
The most important award, I think, that the American Psychological Association gave me an award of my lifetime achievement.
Oh, yes.
Which is unusual. They don't give it to clinicians, they give it to researchers. But I am both a researcher and a clinician, so I received it.
Yeah, so it's beautiful, and also I think that your achievements and the things that you created as the one like the most I think that it's the most studied and with the most the biggest effectiveness in treatment of PTSD. You are a developer of prolonged exposure, which is
the innovator, right?
Yeah, I've been in Poland. Here we had a tract 3. It was the study that were we were trying to compare prolonged exposure to the pharmacotherapy and to other treatment methods, and it shows like his big effectiveness in the PTSD treatment. So I am also personal, like a big fan of you and of your work, because I've experienced on myself how it's useful, how it's effective, and maybe on the beginning, because I've been very fresh and young therapist when I first learned prolonged exposure. But it's great to experience how it's effective in the PTSD treatment.
And prolonged exposure is, was disseminated, has been disseminated in Poland.
Yes.
As well as in many other countries.
Yeah, in the whole world, in a different countries, cultures. So it's very important to say that it's cross-cultural, that the people in the United States, in the Europe, and all over the world, like the prolonged exposure, where the effectiveness were checked, and it's like in the same level on the different countries, different cultures. So it's also, I think, very, very. It shows how it's transcultural too. Methods.
Right.
Yeah, and Thank you. And maybe I did a little introduction of you, but maybe you want to say something about yourself. Maybe there is something also important.
No, I don't. I'm very proud that, I was fortunate enough to develop prolonged exposure and then tested it and then many, there are now hundreds of studies, good studies, controlled studies are showing and its effectiveness and efficacy, in many countries. As you said, including Poland, in many articles, Sweden, Australia, I don't, we don't have time to.
Exactly. And on the beginning, I would like to ask you, what were the beginnings of prolonged exposure? Why you chose the PTSD and trauma, and what was the context of how the PE, starts to how you start to develop prolonged exposure.
Okay. So it was 1980. In 1980, the PTSD, post-traumatic stress disorder, was introduced in the DSM.
Yes.
Then it was the DSM-3 for the first time. And beforehand, it was called in all kinds of names, and but there was no, an introduction of it as a disorder on its own. When it was introduced we didn't have treatment for it. I mean, we didn't, since it was always introduced in different names.
It was a shell shock.
There was no shell shock, right? You're right. Yeah. And so, I was thinking, well, we have to now develop a treatment that will be specific for post-traumatic, for PTSD, right? And that's how it started. Now, I knew that, when, I was, a researcher and a clinician, in Philadelphia, then in Temple University, in an anxiety disorder clinic. So I have seen a lot of rape victims of after, the war, and I thought, well, this is an anxiety disorder. So why don't I start there? And I did treat this patient with, exposure therapy, just a regular exposure therapy. Why don't I start there? But I also knew that PTSD is special because in addition to, usually in anxiety, most of the thing is people are afraid of going to places.
Yeah, they anticipate.
That will anticipate that something bad will happen to them because it's similar, to what happened to them before.
Like worrying, or those
kinds of... No, not like worrying. Like, going to, going on a highway in Pennsylvania because it's similar to highway in Vietnam. But Vietnam was really dangerous. But highway in Pennsylvania, of course, you get all kinds of accident and stuff. But people don't shoot at you, right? Yeah. So it wasn't dangerous, right? More than anything else. But people, stopped going on highway in Pennsylvania when they came from Vietnam because they thought, well, it's too similar, right? And this is
triggers.
No, it's similar.
Similar.
I mean, they thought if it's similar, then it means that I should avoid it if I want to, avoid another trauma, another problem. And then the other thing, that's like any anxiety disorder. But there was something else that in PTSD, that people were afraid of thinking about the trauma. Because they are afraid that if they think about the trauma, they will fall apart, they will go crazy, something terrible will happen to them.
Yes.
That was something special. And I thought, well, if we want to make a treatment that will work for PTSD, we also have to include what I call the imaginal exposure.
Yes.
That it means that you imagine the things will happen, and you find out, A, that nothing happened to you during the imagery, but also that you're not falling apart, that you can actually think about the drama, experience the drama for in the beginning for 1 hour, then 45 minutes. And yes, it's upsetting, for a while, it's upsetting.
What was your reaction, first of all, when you saw people? Because it's like many therapies, they have a belief that I need to satisfy my patient, that I need to calm my patient. And what was your first of all reaction when you
My reaction was that it's the opposite. That what maintains PTSD is the avoidance, and two kinds of avoidance: avoidance of thinking about the trauma, and avoidance of doing things, going to places that are similar. So we have to deal with these two problems. And we're showing the people, that if they go, to the highway on Pennsylvania, nothing really happened to them. Right? Or it's very unlikely. If it happens to them, it's not because somebody is shooting at them. But accidents happen, but they happen rarely. Right? So we said, we have to have two components. What we call in vivo exposure in reality, which is similar to what we do in other anxiety disorder. But then we had a special thing, and that is imaginary exposure in imagination to the most upsetting trauma that haunts them the most. And ask them to tell it in a loud voice, and
first perspective, like it happens again.
And we taped it, and we asked them to listen to it at home. And gradually, they're finding out that they don't fall apart, and they don't go crazy. And as they continue to practice, they feel less and less distress by thinking about it. And then also after the imaginary exposure, we said, okay, we need to introduce, let's talk about it. What did you learn, from this experience, right? And so that's how I developed it.
Great.
And then I did the first study. Started in 1982, but these studies take a long time.
Yeah, it was a year before my birthday. I'm from 1983.
Well, you're young. And so, it takes time, and we published it, and, people were impressed with it. We also taught it, we gave workshops, we gave, so to teach people how to do it, how to use it. And then other people started to do it. People were, kind of interested in it. And so other places like in Australia, in Sweden, and many other places.
All over the world. Yeah.
All over the world, they did studies. And they find out that the treatment is very effective. So for me, I was very happy because it means that it's not only in my hand that it I can be biased and say, well, it works for me because I'm interested in work. I developed it. But when I saw that even now we have about 100 studies, good studies, which we call controlled studies, from all over, I don't even know who does it anymore. I mean,
it's spread all over the world, and people,
I just read about it, and and so it's definitely. I said, well, it works in Sweden the research in Sweden is good, and the research in Copenhagen is good, and the research in Australia is good, and in Germany. Yeah. Then the treatment works.
Yeah, it's. I know from the study in Poland that I've been involved in, that it was like about 80% succeed in the 100% decreasing the treatment, the PTSD symptoms. Yeah, so like people were.
I don't think that it's as many, but I think that 80% are getting much better.
Much better, very, very much better. Yeah, like
40% or so are completely saying, "Well, I don't remember I had PTSD."
Yes,
right.
Yes.
Sure.
Yeah, and from for the first manual, does the PE changed in some ways? Because I saw that I have with me here somewhere. I put here
second edition.
The second edition, and I remember that there was some difference in the imaginary exposure that, but maybe you.
Well, not that much difference, but in the beginning it was 1 hour. Then we said we don't need 1 hour. Maybe it's only, and we go down to 40 minutes.
Yeah.
And now we just finished an experiment, a study that shows, and I'm not yet, recommended it because the therapists were all experts. But now 20 minutes is as good of imaginary exposure. Great. We also added the processing after the imaginary exposure. Tell me what you learned.
Yeah.
How did you feel? And but in general, it's similar. But we used to emphasize relaxation training. We now don't emphasize it. I mean, patients like it, therapists like it, okay, they can do relaxation, but not when they do the treatment. If you sit, let's say now with me, and you get kind of anxious, and you can't stop the interview.
Yeah.
And you can't stop the interview, then you can do breathing, that will calm you down.
Yeah.
Which, it's very helpful, but we don't do it while we're doing the treatment.
Because I think that, we don't want to emphasize the avoidance, like the avoidance of emotions. Is it connected with it?
Right. And we don't want to make people feel that they got successful because they did, they did relaxation training. They were successful because they had resources from their own.
Yeah.
So we want them to trust themselves and not, something else. So that's the reason.
Great. So also the part with the imaginary exposure can be a shorter. Yeah, I think that during your interview with Rika Kigart, yeah, you said that now we can do a shorter imaginary exposure, and also that you will if you will discover PE now, you will change the name from the prolonged exposure to emotional processing therapy. Yeah, am I right?
That's right. Yeah, but once you have a name, you don't change,
Yeah.
If I had to start over again, I would say that it's an emotional processing therapy.
Mm-hmm. Yeah, and
right.
Maybe for our listeners who maybe they are not such involved in the world of trauma or psychotherapy, how you can tell the emotional processing, what it is?
Well, what it is that we teach the people that what they're afraid of it is unlikely to happen.
Mm-hmm.
That's the main thing. And that avoidance is okay and good for the short run because it makes people less upset. But on the long run, it actually maintains the PTSD symptoms.
Mm-hmm.
And that the idea is to teach people to deal with their emotions, to accept that they can be upset for a while, but if they do the treatment, over 5, 6, 7 sessions, the emotions go down, down and down and down.
Mm-hmm. Okay, so like we can process those emotions and then they can decrease after the while.
Right.
Yeah.
Right. And they learn that what they're afraid of that will happen to them doesn't really happen.
Yeah. And I know that some of the patients, when they hear that they will have to say their traumatic memories, they start to also be afraid of talking about the trauma. And maybe you have some ways how to motivate those people, to try.
I tell them that let's try to do it as easy as you can.
Okay.
Just tell us whatever you can. And gradually we said, add in, more and more details.
Mm-hmm. Okay. So
and we give them examples.
Mm-hmm.
We give them examples. And we say, just like, you broke your leg.
Yeah.
And the surgeon says you really need, to have a surgery to put the leg together. But this will hurt you more than just putting a cast and not do the surgery. But if you do the surgery, you are likely to come out of it as if nothing happened, completely cured. If you're not, you may limp for your whole life. So do you want to limp or do you want to get cured?
To get cured,
so we explain to them,
oh, yeah, so
why
it can motivate.
For them, to motivate them. And it's really the things that upset them the most, the sessions, is sessions 3, 4, and 5. And after that, it starts to go down. Session 1 and 2 is introduction, so they don't get upset.
The symptoms.
Session 3, when they get session 3, 4, and sometimes 5, they see they go down in the, distress and anxiety.
Yeah, and they also
They learn.
Yeah.
They learn that, let's say that you see a horror movie for the first time.
I like.
You like it, but I don't. But it's scary. It's supposed to scare you. That's, well, suppose you saw it 15 times. Would you be as scared?
No, it starts to be boring, I think.
That's right. And that's what will happen with you. So we give them examples to help them, motivate them. And in fact, very few people are saying no after you talk to them for 1 or 2 sessions and you explain all of it, that, they think avoidance is good, but avoidance is good on a short term, but it's really maintains your symptoms, and the PTSD on the long term, you want to maintain your symptoms forever.
Yeah, right. I like also the metaphor, like with using the time perspective, like from your rest life. Do you think is it better to hurt a little bit for 2 months, and how it is from your whole life perspective? Like, do you want to be free from the traumatic memories to the rest of your life? Is it worth it? Yeah, so I like it too.
Yeah,
that's how I try to motivate patients. Right. Okay, and what we can say, because also I know that some clinicians, they also, like we were talking on the beginning of our interview, that some clinicians, they are afraid of provoking the traumatic memories, because also some I've been also on some trainings where some clinicians, they were saying that we must not talk about the trauma on the beginning, because talking about trauma can re-traumatize our patients. I don't believe in it.
It doesn't.
Yeah, I know. But what you could say to those clinicians who are afraid, and why it doesn't, from your perspective?
I'm explaining to them the theory, why we do exposure, right? And I say to them, why don't you try? Because what you do, you have your patient for 5 years or 6 years, and you do supportive therapy, and it doesn't help them that much. Maybe it's time to do something else.
Yes, yeah.
And I explain to them why, and we help them, and we give them supervision, and we train them.
Yeah.
So, we have 4-day workshops that we give to train. And then, we do supervision as needed until they feel comfortable.
Yeah.
Until they see their first few patients getting so much better. They learn.
It's great to experience it when the patients, they start to talk that it works. It really works. Yeah. And it's in a relatively very short time, because it's mostly, from my experiences, after the 6 or 7 session. So they mostly they experience the decreasing of the level of the arousal and the
and many people after 8 sessions, they feel great,
Yeah.
And, most of the time, we do the treatment up to 15 sessions. So it's still a very short, once a week, it's a very short treatment.
Yes, yes. And now, according to the war on the Ukraine, we also have here in Poland many Ukrainian refugees, also psychologists, psychotherapists. And my question is, do we can treat trauma when, like there in the Ukraine, there is still bad things happens? When, like from your perspective, opinion, when is a good time to maybe
Well, it's not a good time when they are in the middle of Kiev.
Yeah.
And, they have bombs, all over. But once the situation around them is calming down, but they still have the symptoms of PTSD, that's the time to treat them.
Okay, so if they are here in Poland where they are safe,
they should be treated.
They should, yeah. And
if they have PTSD.
Yeah.
Not everybody that comes from Ukraine has PTSD.
Yeah.
Some do and some don't.
Mm-hmm.
But the ones who do, and after 3 months that I see that the symptoms don't go down, I said, let's start treatment.
Okay.
Why let the patient suffer?
Exactly. And do you think that when someone have the acute stress reaction, but maybe not like from the day after, but after 2 weeks, 3 weeks from the trauma happened, is it according to your experience, the guidelines, is it okay to like do some parts of PE, or is it better to wait?
No, it's okay after 3 weeks if they continue to be very severe.
Severe, okay.
If not, you wait a little bit more, and because for many people, the symptoms go down by themselves with time. And, it doesn't hurt to start treatment earlier, but so.
Okay, no problem.
But it's a waste of resources. There are so many with PTSD. So you don't want to start treatment after 1 day, where you know that for the most patients, after, a month, it will be much better.
Yeah. And, okay. How do you think, what are like the main factors that differentiate people that one would develop PTSD and the other people not? What are, according to your...
There are many, many factors.
Yeah, I know that this is many, but maybe from your experience, for you, there are some more important.
The ones that are most important is, how severe the trauma was. The more severe the trauma.
So the more type of trauma.
Yeah. So that's one reason. Well, another reason is avoidance. That, some people, I had the car accident. The car was total, but I didn't have, anything happen to me. But I couldn't drive to work. So I called my husband and I said, take me to work because I have a meeting. And I didn't come home and sit down and be starting to avoid and say, it's dangerous to drive, so I stopped driving.
Yeah.
So avoidance is another very, very important, reason.
Yeah.
So
I also
people that don't avoid.
Yeah.
Go ahead.
Yeah, I wanted to say that I also had some traumatic events, and the knowledge from your books and your workshop helps me, I think, to not develop also probably, but I think, yeah, that it helps me a lot that I didn't start to avoid things after it. Yeah. So it's important.
Yeah. Yeah, that's very important, because if you don't avoid and you continue your life, you are likely to say, well, I'm continuing and nothing bad happened to me.
Yeah.
I continue to drive, and I don't get another accident like this, because you don't get it every day. And I continue to think about it, talk to people about it, and I don't fall apart and I don't go crazy.
Yeah.
So I'm learning that it's good not to avoid.
Exactly. And is it often does the during imaginary exposure, do sometimes people dissociate or do something like?
Very few people dissociate.
Few, yeah, okay.
Yeah. And if they dissociate, usually they kind of stop talking to you. And so, they are kind of there. And you kind of say, David, wake up.
Yeah.
And you get them up and you walk with them, and maybe you walk outside and they get over it, and then you start again.
Yeah, they come back to their body. Yeah.
Yeah, right.
Yeah.
And very few people get, almost nobody get worse. Some people don't get better. We were talking about it. No treatment helps everybody.
Yeah,
but people don't get worse. We have studies that show that people don't get worse.
Yeah, exactly. I've seen the meta-analysis that were made on 1,000. I think that there were soldiers from Vietnam that they didn't finish 100% PE, but none of them get worse from the big. I forgot in English how it's the exact word, but it's 1,000 people, so it's very big amount of the to measure. Yeah.
Right. It's valid.
Yeah. Exactly.
Right.
And is there can we treat by PE also the complex PTSD?
Well, I don't believe in complex PTSD, and I'm not the only one. Many of our experts, PTSD is complex.
Anyway, in general,
In general, because it has a lot of comorbidity. It comes with depression. It especially over time, if you don't get treated earlier. You develop, alcohol abuse and, drug abuse and a lot of other things. And the other thing is that, I want to say that of the people in general that went through a traumatic event, in general, some of them mild, some of them severe, only about 10% develop chronic PTSD. So, so the remaining patients, get well by themselves if they don't avoid.
Right, yeah. Yeah, I've asked because now in ICD-11 we have the complex PTSD, but it's also the symptoms of the normal PTSD plus some symptoms of personality disorder. Exactly.
Really, the PTSD is not complex, but some people, as I said, have complexity. They have depression, and they have personality disorder.
Yeah.
And, in 15 sessions, you don't cure personality disorder.
Yeah.
Maybe we don't know how to cure personality disorders at all, right? So if we talk about complex PTSD, we don't talk about complex PTSD. We say PTSD plus
some other features.
Yeah. And the PE works for PTSD and for depression also.
Yeah.
And for many other things. Guilt, shame.
Yes.
But it does not cure everything. It is a treatment for PTSD.
Yes.
It's not a treatment for personality disorder. If you want to treat personality disorder, well, you can try to treat personality disorder, but don't tell us that it's complex PTSD.
Yeah. I've seen also the DBT PE protocol that it's special for it's the kind of the prolonged exposure plus some techniques from dialectical behavioral therapy for people with borderline, and it's also the same very effective.
Yeah, but we don't cure the personality disorder.
Yeah,
we
PTSD.
cure PTSD even if people have personality disorder.
Exactly.
But we are focused on the PTSD, on the depression, on the guilt.
Yes.
We don't focus on curing the personality disorder.
Yeah. Okay. And the people also also many times people with PTSD, they also have some comorbid problems, and one of them is the alcohol or drug dependency. And I know that in Poland many years, maybe not many, but some years ago, there was a belief that first of all we need to cure the dependency, then the next we can cure the PTSD, for example. And my question is, how does it change? What's the newest guidelines?
No, I mean, we did a study, and others did, similar, showing that the best thing is to treat them together. Because usually, you go to your therapist, and you say, well, I have alcohol abuse, I depend, and they said, okay, take a treatment for alcohol dependence, and then come to us with the PTSD. So what happens is that, they get the treatment for the alcohol abuse, they stop drinking, but then the PTSD symptoms goes up, because part of what happens when they drink alcohol is to relax themselves.
Yeah.
And so then they get back the PTSD symptoms, and then they go back to the psychologist, and he said, well, you have to stop drinking. They start drinking because they don't like the symptoms, and then they go back, and the psychologist said, or psychiatrist or whatever said, well, we can't treat you. Go back to treat your alcohol.
And he's still working. Yeah.
And so we said, no, we should do it together.
Mm-hmm.
So we did a very famous study where we took people with severe alcohol dependence that were still, when they go to the treatment, they drank a lot.
Yeah.
And we started by detox them, for about 4 or 5 days. And then you immediately started the PE.
Yeah. And
together with, no drinking.
Yeah.
And the results are excellent.
Oh, great.
So this way, you don't have to wait for, because if we wait, people with alcohol or drug abuse will never get treatment for PTSD.
Yeah, because they still will, like you said, in this vicious circle. Yeah, yeah.
That's right. It's circle.
Yeah. Right. I have also your protocol where there is a special protocol, the PE plus the alcohol. I think, this is alcohol dependency program treatment. I forgot the name of this program, but it is available. Yeah, and I'm happy with that is.
Yeah. But I'm not the main author in it, Sudi Beck is the main author on it, and I'm the second author. But, we did, the study is not exactly what we did, but the idea was to do it together.
Yeah.
With alcohol.
And did you try it with some also other substances that people can be?
No, we actually didn't. We wrote a grant to do it with drug dependence, and we didn't get the money, and we just we had other things to do, and so we just gave up on it.
Yeah. But I think that the alcohol would be the most popular drug, because it's calm very fast, and it's like easy to buy it. And
right.
Yeah. And do you think, is there any ways to do you still think how to and no, I have a thought, is it necessary, but maybe I just asked, do you try to also develop the PE in some way, or is it for you the complete method? It is complete, but sometimes people think how to.
No. I mean, we now are doing a study in which we're doing, we combine PE with estrogen for women. Mm-hmm. And, we have an idea that the estrogen combined, will facilitate.
Why estrogen?
Estrogen, right.
Yeah.
Mm-hmm. So we are in the middle of the study. I can't tell you what will happen. Right?
Okay.
And so we are, doing things, like we just finished a study on, on 20 minutes versus 40 minutes of emotional exposure. So we are trying to improve and get, better and better.
Mm-hmm. Okay, and maybe you can say something about what, in your opinion, is the future of the trauma treatment? In which direction?
Right now, we are happy, with nobody, no treatment in the world, not physical, not psychological, is good for 100% of the patients.
Yeah, we all know that.
And so we want to improve, like the estrogen,
to other.
Mm-hmm. Yeah, to, make it better. Yeah. That's kind of in the meantime. Now, what will happen in the future? Maybe there will become treatments that are better. I don't know. People are trying all kinds of things, right? And maybe, they will find better treatments. Now, this is probably the best treatment we have.
Yes.
And the medication don't work so well for PTSD.
Yeah, now it's during the guidelines. We should the gold standard is the prolonged exposure rather than the pharmacotherapy. Yeah.
Right. That's right. And so this is what we have, in the meantime. Well, people are working and continuing, and hopefully, I would be happy if somebody comes with treatment that are better. Right? What we want is to help patients.
Yes.
It doesn't have to be my treatment.
Yeah, and have many to grants to have an opportunity to do those studies. Yeah, so
Right. So, we'll see what happens. Right?
Okay.
We are doing what we can to make the treatment more effective, more efficient, shorter.
Yeah.
And, see, how we can go about it. And other people may come with new ideas. And that's good.
Great, yeah.
If they work, it's good.
And
especially if they do treatments, if they do studies to show that that their treatment works. Because a lot of people come with ideas and they don't have evidence that it works.
I think that what I saw, that there is some people that I don't know, is it like because of our times that happens that people start to be opposite to the science. I mean, there is more and more people that they believe that the earth is flat, for example, and that there is some hidden the mysterious, and they
they are wrong.
Yeah, exactly, they are wrong. Yeah, and they are opposite to the science, and they discover some methods.
They're opposite to science, and they, if you go to the doctor and say, here is a pill that will help you, we have evidence for it. Yeah. And here is a pill that I like, but but we don't have enough evidence. Which one would you take? Yeah. I would take the one with evidence. Right?
Yeah, exactly. But those kinds of people, they might say that, there is a big conspiracy in the pharmaceutical companies that they want to sell you those pills, and there is some kind.
I'm talking about pills. I'm talking about psychological things.
Yeah, exactly. Yeah, I know. Yeah, but it's great to follow the science and do the evidence-based treatments.
Right. And also with medication, people are trying to come up with better medication.
Yeah, exactly.
There is science in medication. Right.
Great.
And if people don't follow the science, then, they don't follow the science for physics. And they don't follow the science for biology. Right?
Yeah.
It's not a difference. You can say, well, I don't believe in physics.
But you don't have to believe in physics to experience physics, because you're walking on Earth and the gravitation works. Yeah.
Not in physics, but in all kinds of ideas about how physics works. So we don't believe in it. There are people who say, but we don't believe that the change in what happened in the climate has to do with human beings. Well, they don't have to believe.
Yeah.
You have to go after science. You don't go after belief.
Exactly. Yeah.
You believe it's good for reading newspapers.
Yeah.
It's not. It's not for science.
Exactly. Okay, Professor Foa. So I'm checking my notes. Do I miss some important questions that I wanted to ask you before?
I think you were wonderful.
Yeah.
You asked all the right questions.
Oh, thank you.
You did your homework. Yeah.
Thank you very much. It was like.
No way.
Thank you. And I want to thank you also for your openness, for sharing your experience, your knowledge. It's a big thing for me, and I think for the clinicians here in Poland, and not only clinicians, I think for many here people, psychologists, like it would be wonderful to have the knowledge here from you. And thank you from the bottom of my heart. Yeah, it was an honor, big pleasure.
Thank you for taking the time to, to share to let me share my knowledge.
Oh, it was a pleasure and honor to have you here with me. So thank you very much.
Continue your important work.
Thank you. I will.
Bye.
Bye.
Bye-bye.
Bye-bye.